Good morning, good afternoon, good evening. It depends which time of the day you're watching this video. I'm grateful for you to make the time and the effort to watch this video. My name is Shamsi El-Hasani. I am consultant surgeon in upper gastrointestinal surgery. My subspecialty and interest is weight loss bariatric surgery. I lead on the bariatric surgical services, my NHS organization, and I am also the clinical lead for Kent Weight Loss Surgery Center at Chelsea Park Hospital, which is a bariatric center of excellence accredited by IFSO, which is International Federation for Surgery of Obesity, and there are only few centers of excellence in the United Kingdom. I must say the contents of this video are my personal views based on my readings, my studying, my certificate, mainly the experience I have with my patient, attending international and national meetings, discussing with my colleagues and peers. I am fully aware that other colleagues of mine who do extremely good job may have different views on some of the points that I will raise. The aim of this video is to help our patient in their choice and journey of weight loss surgery. I will display the common bariatric surgical procedure, and we start by the gastric balloon, which is a procedure, temporary procedure, inserting balloon into the stomach through a camera through the mouth. Then the gastric band, which is insertion of a silicone band around the upper part of the stomach, and then the stapling procedures, which are the gastric bypass and the gastric sleeve. For the purpose of time, I will limit this talk or video to the gastric sleeve and the gastric bypass. The gastric bypass as a primary, effective, successful bariatric procedure had appeared in 1952. The principle of this procedure is to help individuals to eat less, absorb less, and the combination, there is hormonal effect that help to decrease the hunger and the craving for food. Stapling the stomach to make it effectively a small stomach, to eat less, to feel full, and bypassing or excluding part of the initial of the small bowel, create a situation of decreased absorption, and the anatomical change created in the abdomen will create the gut hormonal changes that will help to decrease the hunger, the craving for food, and also have metabolic effect that will help patients who have diabetes or hyperlipidemia. Now, over the years through the globe, colleagues of mine had tried their best with goodwill to modify this procedure to get better results with their patient. So we have the long pouch, the small pouch, the long excluded segment of the small bowel, the short excluded segment, and different types of doing the junction between the pouch and the intestine. As I said, all of them with goodwill to make better results for our patient. However, I think the last or the recent modification of the gastric bypass into the what's called mini bypass, or one anastomosis gastric bypass, or single anastomosis gastric bypass, all of them the name of the same procedure, is basically a revolution in the evolution. Now, the new bypass has the same theory or the same principle of the old bypass. The pouch is longer to create more period of satiety. The excluded segment are longer to present better and more lasting effect of weight loss. In my career, I have done over thousands of Roux-en-Y or two anastomosis gastric bypass, or a classical bypass, or old bypass. However, after 10 to 15 years, I realized it was not as good as I thought. And hence, since 2013, 2014, I migrated to the new mini bypass or one anastomosis gastric bypass. I still do the Roux-en-Y gastric bypass or the classical bypass in special circumstances, especially for revisional surgery. But I can see that the initial effect, the results are happier for patients and myself. When it comes to the sleeve gastrectomy is an excellent operation, but it has its own certain indications. The principle of this operation is to remove the majority of the stomach, leaving a smaller stomach to eat less to feel full. Removing the upper part of the stomach, called the fundus, will initiate a hormonal change that helps to decrease the hunger or craving for food. Common question from my patient: how much stomach you are going to remove? And I also say that the correct question is how much of the stomach I am going to leave, because this is what you are going to live with for the rest of your life. Myself and all my colleagues use a calibration tube. We put it in the stomach, basically to measure or to size the stomach that we are going to leave. Outside this measurement will be stapled and excised. The end result is a small, long, narrow stomach, help individuals to eat less, to feel full, and it has the hormonal changes we indicated. Now, frequently this is a dilemma for our patient, what to choose, whether it is the gastric bypass or the gastric sleeve. And I would say the guidance is, on average, in my opinion, the bypass here and the sleeve here. On average, the bypass will provide a more percentage of excess body weight loss than the sleeve. The risk of weight regain in the future is more with the sleeve than the bypass. The hormonal effect is stronger and more lasting with the bypass than the sleeve. The possibility of heartburn following the operation is more with the sleeve than the bypass. The bypass is completely reversible. The sleeve is the only irreversible operation. Once we take the stomach out, we can't put it in again. The bypass can be adjusted by decreasing or increasing the excluded or bypassed segment depending on individual needs. The possibility of dilatation or stretch of the pouch or the sleeve is more than the bypass. And also, God forbid, if there is a problem after the operation, such as leak, if it is with the sleeve, it is very difficult to treat. It is easier to treat with the bypass. So I tell all my patients, please read well, please research the procedure. It is a life-changing procedure, something you will live with the rest of your life, and you don't want it to be revised. Don't rush and jump into a procedure. Myself and all my colleagues have a consultation with you, asking you questions. Every question has a meaning. At the end of the consultation, we'll give you our opinion. What are the options for you? May give you one option, two options, three options, and what are the one, what are the two, and we have reasons. Please ask and we will answer you. Just remember, my aim is your aim, to have a safe weight loss surgery, to have a safe journey. And my aim is your aim as well, to have successful, long-lasting weight loss surgery. And my aim is to bring happiness back. I hope this video was concise enough and you are not bored for it. And I wish you all the best and successful weight loss journey. And thank you for listening.